Our first presenter is Dr. C.J. Peak, and he received his doctorate at the University of Colorado Boulder under the direction of Dr. Peter Osorio. And he said he's been working to do better integration of behavioral health and general medical care since about 1974. So I'm thinking he began that work even before he was fully degreed, but he can tell us more about that in the question and answer session. He's helped set up integrated behavioral health in medical settings, bringing about system-wide change. He's published and presented widely on his topics of interest, changing and making better healthcare systems. He's presently at the Department of Family Medicine and Community Health at the University of Minnesota in Minneapolis. He is a professor there. So, Professor Doctor. I met CJ on the phone. As my memory tells me, it was about 1975. I was finishing my internship, and my friend and mentor at the time, Ray Carlson, had obtained for us some tapes of Dr. Osorio's personality and personality theories, and we were spending our lunchtime and then some listening to those tapes. I think CJ had a hand in producing those, but at any rate, as we were finishing up those tapes, Ray says to me one day, "Hey, look, this guy's up in San Francisco, and he's got some of these new things that they've been working on at the university called images. You need to give him a call." And I remember being on the telephone with CJ, avidly writing down as fast as I could the descriptions of the images that he was giving me. And I'm still grateful for that. That was another part of my introduction to Descriptive. Today, he's going to continue in his fashion of making the world of healthcare better by assisting us in understanding the notion of the necessity of shared language. So I give you Dr. Peak.
Well, thank you, David, and wonderful to see all of you. So I'm going to embark. I'm going to share my screen because I have some slides, and then we'll go from there. Can you see that okay? So, yes. Okay, great. So here's the thing about this. The purpose of this presentation is a DP application. It's really not new DP. It's not even in the application of specific DP methods. It's instead applying a DP sensitivity for mapping out complex subject matters and making it easier for people to navigate them. It's the kind of thing we saw Pete do at the board all the time, and that many of you have done on your work and papers here and elsewhere. In addition, this is the application of a dimension of descriptive associated strongly with Tony Putman, that is leading groups of people to shared language and sensibilities about complex subject matters, bringing people together to share enough to do things together. So, here they are, Pete at the board mapping out a subject, and Tony helping to facilitate a shared recognition. So hence the name of this topic is shared language for shared work. And the reason I'm bringing this is it takes streams of effort converging from many different quarters to accomplish big things. Like no single individual discipline, knowledge-based perspective, identity, skill set, or sensibility. And a start to making that possible is good enough shared language rather than constant quibbling about what things mean and whose language is better. Have you ever witnessed any of that? Quibbling about what language is better, whose talk should dominate. Okay, so I'm going to bring two examples published in 2021 that were amplified by the COVID pandemic and the civil unrest over racial justice that really was triggered right here in Minneapolis by the George Floyd killing. So in both cases, the practical task was to achieve good enough shared language, intellectual frameworks to enable people to move forward together in shared work with less confusion, ambiguity, and conflict before. In descriptive, that's mapping out the subject matter. So the first one is called Coming Together in Action for Equity, Diversity, and Inclusion. This is the story of our family medicine department path on down that road. And the history was the faculty really wanted us to do something as a department back in 2019 to get better at equity, diversity, inclusion. There's a lot of faculty saw problems and we really needed to grow. There were so many growth areas. We weren't really up to where people wanted to be. So the department has said, yes, let's do that. And so they asked me to facilitate, help design a process and facilitate it to bring the whole department down a path. And the emphasis on this was to get the department off on the right foot, get the effort off on the right foot, making being constructive the most attractive alternative instead of being cynical, or negative. Because many such efforts in academic settings have been troubled and they've served to divide people. You may have witnessed that or heard about that, but a lot of these efforts make people feel bad and divide people. And it's not, you have to get them off on the right foot. So that's what the assignment was. And so part of it was to get a shared intellectual framework and a shared process. So one of the things we did is I didn't just do it, I enlisted a broad design team of faculty throughout the department, like 7 or 8, and a couple of consultants, like a vice provost for equity from the medical school, and said, let's all design something together and bring it to a big meeting of 65 faculty and administrators for 3 hours to make a big splashy start. So that's how it was. So one of the things that we realized that family medicine people can be reassured in very sensitive areas and where there's foreign content by having an intellectual framework to make it navigable. I mean, it makes people a lot more relaxed than venturing into a wilderness. And so the definitions of terms and the subject matter. So what's the work? So I'm going to show you the design team came up with an intellectual framework. And I'll tell you the reason this is that this helps you figure out what is the subject matter, what is the work, and what do things mean. So this was evolved as a basis. So you can see it was called 3 Pillars of Action for Equity, Diversity, and Inclusion. And in a way, it's a way to say, here's the subject, here's the assignment. So you've got, in a family medicine department, you've got frameworks people already use, like healthcare delivery and health, care delivery and health, workforce recruitment, retention, learner recruitment and training. And then here's the things that we're concerned about: diversity. So we have patient diversity, workforce diversity, learner diversity, and in research, which crosses all the pillars, participant diversity, without prejudice of race, ethnicity, and so forth, okay? So then you got equity, which is a value, principle, and a goal. So you got health equity, workplace equity, educational equity, and research equity. The absence of avoidable, unfair, remedial differences, and so on. And then you got inclusion, which is making good use of the diversity you have. So that means bringing people in and having them want to stay, really not only having diversity, but really making use of it and being inclusive. So patient inclusivity, workplace inclusivity, learner inclusivity, and research. Equal access to the opportunities, interactions, and relationships. So basically, this was put out as the framework that this is the subject matter, and this is the work. And our job is going to be to start populating the cells. Now, there was another part of this that we had to add, which is common terms, realities that shape how you can achieve equity, diversity, and inclusion. So, there's social determinants, which are influences. And those are, play out in health, workplace, and educational. These are the social, economic, environmental, and policy systems responsible for disparities. And then you have the disparities, which are consequences. Health disparities, workplace disparities, educational disparities, research. And especially for patients, communities, and persons underrepresented in medicine. So that becomes the the intellectual framework, which we put to the big group, and people said, "Oh, this is really helpful. I can see how to get around it. I can point on a page what I'm talking about. I now understand the difference between equity, inclusion, and diversity. I understand that social determinants are influences and disparities are consequences." There's a lot of little moves in there to help clarify and distinguish some of these terms, which often are kind of people are often swimming in them. Anyway, so that was a way to start. And then, but we also had to have a shared sense that there's a problem here. You know, in the room, what's the common reality base to go from? And so we did a vignette of actual stories that took place, our residents told us, in the various clinics and the hospitals. And these vignettes were a little bit disturbing, and we asked, after we read the vignettes, we said, what's the one word that comes to mind? And then it was on the clicker thing, and this word cloud came up. This is what people felt like from that. So people are staring at this and saying, you know, we do really have a problem. You know, and it's all of them seeing this come out in live. And then we said, okay, we also know people were at all different places about this topic. Some really nervous about it and sensitive, others very confident about it. Some for whom it's a really burning issue, others where it's like, well, I'm not sure how relevant it is. So we asked them, we wanted this all to be out in front of everybody and live. So we had a poll here. What extent do issues of equity and diversity play out and mean something in your day-to-day work? So a little over half said it's a big issue, and then it trailed down. Nobody said it rarely is, but there's a spread of how relevant this is day to day. The other question was, to what extent do you feel comfortable and confident for working with a broad area? And so, you know, there were a few, 10% were well prepared and confident, but most people were not. 70% were like not so confident and not so comfortable dealing with this. And a few were really downright, it was unfamiliar and scary. So people knew in the room, this is the range, and the process, we're going to have to accommodate everybody, and everybody's welcome, and we accept that everybody's where they're at, and that's what we're going to do. So then that's the chance to sit people down on tables and figure out what are we going to do. And so there was a big group of these 65 people for 3 hours. And basically here was the format. In the 3 pillars, care delivery and health, workforce, recruitment, and retention, what's the growth area, our developmental, what we really need to get better at? What are the suggested actions and who could lead them? And what's the first step? Interestingly, we put these tables together because it turns out our faculty was evenly divided between those whose main passion was care delivery and health, you know, health disparities. Others were about workforce, and others were about learners, recruitment and retention. So they all went to their own tables and they simultaneously worked on this. So again, this is formatting the space so they can navigate it and so that they can get through it. You know, it's sort of like, as T quoted yesterday, perceptions without concepts are blind. People in this room were bursting with perceptions, but before this, there was no real bookkeeping system, and certainly not a shared one. So the task was to supply the content, to populate the cells in the 3 pillars and in this whole kind of intellectual framework. And people found that they were very comforted by this because now they knew what to work on and they could point at what they're talking about. So this is also like a metaphor that I love. Is every vine needs a trellis. Without a trellis, irrepressible human energy remains on the ground in a tangle. And this is so often when you get a group together, there's tons of energy, but without the concepts, there's it just is a tangle on the ground, and it's confusing, and the energy is frustrating and not liberating. Anyway, so that was it. Now I'm going to cut. There's a lot of ongoing work for 18 months and so on, but I'm going to cut to something else that's part of the intellectual framework here, and that is when we look back at how we actually operated. I sort of abstracted, here are the operating principles that we've been working on. We didn't set out with these, but when you look at our actions, this is what we had done. And then this was shared widely so that people could see this is our way of operating. This is us and our way of operating. And so it's another kind of concept. So there was three categories. How do we approach the subject matter? Well, we take on the whole entire complex picture in the department, not just a piece of it. You know, care, workforce, all of it, all the isms. You can't just take one little piece and go, because that leaves people out. You have to just do it all together. Begin with a broad intellectual framework with definitions and the scope of work, which you just saw. And then the other there is focusing on problems found in the actual work rather than in abstractions or societal problems. One of the ways these efforts go wrong is that the focus is on what's wrong with society, what's wrong with you, what's wrong with this sort of general thing, the history. And it can go down a rabbit hole, and it can in a lot of cases, it makes people feel bad. So we said, look, all we're going to do is focus on actual problems and come up with actual solutions. We don't do abstractions here. We just do what's in front of us. So that's approaching the subject. Now, approaching the journey itself. So you lead with actions on problems you already see, with the knowledge and skills you already have. And then a felt need for consultants may arise. Other groups have started with consultants. They train everybody. They have people do surveys. They analyze you, and everybody's sitting there like on a specimen. And the thing is, what we do is we already have a lot of collective wisdom. We're just going to start that, and that will create the hunger for more training and consultants. And then, of course, except it's a longitudinal developmental path. It's no quick technical or narrow fixes. It won't change overnight. So be patient. This is a multi-year thing. And this one here is 6 is really important. Think of change as a social result. It's a social result of what we do together as a community of doctors and administrators and learners. It's more than the sum of private individual changes. It's not like everybody gets a private salvation and they sort of recognize that they're racist or whatever, and then they, mea culpa, and then that's like a lot of individual thing. We say this is a social result, not a sum of a whole bunch of people somehow getting the word. And then approaching the people, you treat people as you need them to be, which of course I picked up from Tony, that phrase. A growth mindset that the capacities aren't fixed. Everybody, we're going to believe in them and us. Everybody's a work in progress. And design an inclusive process that brings out the best version of everybody. See, this area can bring out anger, it can bring out bad behavior, it can bring out fear. So the way that we operate, the way people interact, is that the process is bring out the best version of everyone. And that means that, in a way, doing it constructively is the path of least resistance. That's where the support is. There's very little support, and the processes give you very little room for bad behavior. I mean, it's like you'd have to really go out of your way to do that. And then the final one is really important. We favor ordinary language understandable by everybody. This equity, diversity, inclusion is full of all kinds of jargon. And we say ordinary English can convey everything that the EDI jargon does. So we're going to use just plain English. And you guys that are experts can talk about intersectionality and everything, but we're just going to use English here. Okay, so that was the principles. So I want to just close this part. I'm giving you this because it's an example of creating an intellectual framework. So there's concept and content, but the content can go into some bookkeeping system. This work is going to come out in the journal Family Medicine next month, which is one of the major family medicine journals. It's already published online in that journal. And it's funny, exactly 1 week at this exact hour, 9 a.m., we're presenting this work to many family medicine departments on the East Coast, about 25 family medicine departments. We're doing a virtual plenary for several hundred people in family medicine departments. But we're going to do the whole thing, not just this intellectual framework, but the whole path. And so that's this example. Now, I'm going to switch now to another example, and then we'll take time to converse about all of it. Okay, so this next one I'm gonna, is the pandemic. This one is called Shared Language for Shared Work in Population Health. Now, the pandemic and the racial justice crises also amplified the felt need to do better with the health of populations, wherever you are, your own population, your own clinic, or right around you, because of the pandemic. And we saw the disparities and difficulty with minority folks and people of color, how it's getting much more worse. You get a lot of amplification of the inequities. And so we need to deal with the population health idea, which is essentially a collaborative thing with care delivery, public health, community organizations, and so forth. But the problem is this, that terms population health, community health, public health are often used interchangeably, but imprecisely, leading to conceptual and practical misunderstandings. So the shared definitions enable people to create an agenda for shared work, make it possible for people, different disciplines, roles, types of organizations, and age groups to work together on behalf of a larger goal. And that was, it's strange to say that that whole area of population health is a set of terms that people were all swimming in and had been for some time. So for example, you put people in a room and you say, who's doing population health? All the hands go up. But when you go around and ask what they're doing, they're really different things. And they don't even mean the same thing by population.
Is this the right screen? Is this?
Yeah, this is so far. I haven't switched to the next one yet.
Oh, okay.
Okay. So they're meaning very different things. They don't even have a shared view of population. And actually here, this is the right one for that. So like, if what you mean by population depends on where you stand. So if you're an insurance company, it's people covered by your product, and they're called members, enrollees, covered lives, that kind of thing. If you're a medical group, it's people assigned to receive care. It's your assigned patient or your panel. If you're an individual practice, it's whoever shows up for care, my patients or my neighborhoods. And if you're a community organization, it's groups of people with a shared characteristic, some interest, risk factor, geography, or other commonality. So at the table, there's this unspoken thing. So everybody says population, and they mean all these different things. And then there's confusion, ambiguity, and conflict when you try to keep going with the discussion. So the thing is that, you couldn't get through a conversation with, what do you mean by that? Or is this the same thing as that? And this was beyond ambiguity to strong feelings about things and meanings of things in your own guild and your own tradition, and things that have to be protected and observed. And it's quite thorny in practice. And a lot of people who are the authors, there's about 12 authors to the paper that's actually came out last week in Annals of Family Medicine. And the 12 authors were people in the crucibles of population health that were struggling with these things in their own areas. And we banded together, I led that group, to come up with this sort of shared concept for what all this means, which I'll show you shortly. It is sort of like, so that paper offers an example of shared language based on common understandings. And it's hopefully to help people move forward with less confusion, ambiguity, and conflict. And as Mary Roberts quoted yesterday, perception and conception are both essential in achieving knowledge. And we had perception, but we didn't have shared conception. And so I might add to that perception and conception are both essential to concerted action as well, which was the challenge with this one. So I'm going to show you this lexicon diagram in a kind of a stripped down way. And this published in the journal. This was like, how do you navigate the territory? So the top, it's sort of a ladder kind of concept, a significance ladder. The goal talk is at the top, and the how implementation talk is at the bottom. So for example, health is the ultimate goal. And then I'll say that inside all of these bubbles in the actual publication there are specific definitions, mostly anchored in the literature, that make these hang together. But here's the gist of it, is that health is the ultimate goal. Population health is that goal expressed in measurable form. And community health is a population health outcome expressed for particular communities. Now, it sounds trivial, but the fact is, around the tables, people didn't make those distinctions between health, population, and health community. When you just show that much, people say, oh, health is the goal, population health is that goal in measurable form, and community health is for particular ones. Hey, that's helpful already. I mean, it's funny, but that simplistic clarification was useful. So then there's the realities that shape how goals can be achieved. So the social determinants of health. Now, it's interesting, I asked once people around my table, around my office, can you be really clear about the difference between social determinants, health disparities, and health equity? Tell me exactly what's the difference. And people fumbled around. And so what we realize is that if you say that social determinants are influences, health disparities are the effects, and health equity is the goal and the principle. And it's funny, when you say that, people say, oh, that's helpful already. That's clearer to me now than it was before. And then I spelled out this other one, that these background realities include private and public policies, payment, insurance, illness classification and coding, implicit bias. And then this one is something that group really wanted to put in there, which is so DP, you might say. Underlying epistemology, the theory of what counts as real. For example, people speak of lives, problems, and troubles, what besets families and communities, while healthcare speaks of diseases, diagnoses, and codes. And so those are the background realities that have to be taken into account. Okay, so now you're moving down the ladder to how to get things done. And so there's healthcare delivery systems, which are the private and public provision of care. And mostly it's private. It's like private good. You buy a health plan and you go to the clinic. Inside that is primary care. And then you have public health, which is a population-based civic level. It tends to be civically funded and organized for the whole population. And then those are the two ways to get it done. And then a broad zone of collaboration to achieve community health as a goal, which is a way of operating an active partnership with served communities. So this is trying to distinguish healthcare delivery and public health and the kind of collaboration, and that the delivery is tend to be a private good and the public health tends to be a public good. And then this collaboration, and then examples. There are 3 examples shown here. They're all defined in that. So this was a way to help people navigate at tables. And this is what it looks like. Don't try to read it. This is what it looks like in the journal. Actually, not in the journal. There's a downloadable handout that this looks like. This is it. That's made to print on 11 by 17 paper and put up in your cubicle or use it as a handout, which a whole bunch of people have done already. So here you can see that same format, but there's the actual definitions, and on the back page there are all the references to everything. And so this is, that's the, this kind of context for that. So, we offered this as a invitation for conversation, not as the final definitive lexicon and meanings. We said, this is that the authors came up with from their working in their crucibles of population health, but it will no doubt evolve as other people besides professionals and people from other disciplines and perspectives come in. And we're going to invite the conversation and hope that you will help us evolve this to represent how we act and move it more and more into the future, into a better future. We did this as a description of the current now, rather than as an ideal future. So it was like, here's what you're going to encounter now, how to navigate it. It's interesting. The conversation already is starting to occur on the Annals of Family Medicine website with letters from people and then responses. And I'm collecting all those. And the authors will take a look at this stuff in a few months and then evolve that. And even though we can't republish the article, this lexicon diagram is on the web server from the, we can evolve the diagram as we learn and have a little essay about, here's what we heard from all of you. Here are the changes that we've made. here are the things that are going to be less familiar, more familiar. So it becomes community. It's the idea of a shared, evolving framework of reality. So anyway, that's basically the content of these two efforts that to create shared language for shared work in these two highly pressurized areas. And again, it's that idea of having the content and the booking. Here's the cartoon. You think this is bad? You should see what's inside my head. And the fact is that in both the equity, diversity, inclusion, and the population health, what's inside people's heads has been disorganized, and they don't say it. And then so this poor guy saying, "Gee, I'm wondering about a bookkeeping system." And here's one of my favorite quotes. My friend Frank Degree, who has been chair of family medicine at Denver, he said in a big group once, he says, "Descriptive psychologists help you be clearer about what you're looking at." And that's one of the best answers to what is DP. And so these two projects and papers are examples of a DP person helping people be clear about what they're looking at so they can move forward together. So thanks for that. And I think here are the articles. If anybody wants to do it, I guess I could put them in the chat at some point too. But you can read these now. It's funny, one came out last week and the other one is about to come out next week. They came at the same time. I'm lead author on both of them. So this is the time we can now go for conversation, and I'm going to stop sharing my screen.
Great, thank you for that engaging presentation, and we do have a good amount of time for Q&A. I don't see any cues coming into the chat at this point. So if someone simply wants to pipe in, that's fine too. We'll have the floor.
Well, I wish we'd had this a few weeks ago, actually. I'm president of my local League of Women Voters this year, and we were supposed to be setting our priorities, and actually this would have been really helpful because it's kind of a mess, actually, trying to sort these things out. So we have some priorities that are state league sets, and then we have some local things to look at, and then there's the issue of how much manpower do we actually have to do some of the things that we want to do? What are the things we want to do? All those things. And I was just thinking about how this would have been a really useful way to, how important that bookkeeping system is and how we could have used that. But maybe I can come back to this. But I like that idea that the bookkeeping and getting, there was just so much in what you said. I think getting the straight what we're doing here and getting the correct bookkeeping areas here for people to fill in, how important that is to help sort out what are we talking about and how to proceed.
Yeah. So I'm sure you've all had times when you encountered this cacophony and you can't get through the call because what does that mean? I mean, but you can just take it on as a descriptive psychologist. You can just decide to map it out. And what I found is that the minute you start, people really appreciate it because most people don't try. Most people try to show how they talk, where it comes from and why it's good. Not to back up like a sociologist or something and try to figure out how do we understand this. It's funny because sometimes it's really simple, like that thing about social determinants are influences, disparities are consequences, and equity is a principle and a goal. It's funny, that's trivial, but a lot of people couldn't be clear on that right away. So think of your own situations and take it, you can take it upon yourself to start mapping out these things.
Thank you for that. And then I have Ralph, who has a question, followed by Charlie Cantor.
First, maybe I have comments more than questions. Number one, I just am always delighted when you present CJ and just to see the way that descriptive psychology has infiltrated something so important. And your work and the legacy of Tony Putman. It's just wonderful to always see the work you're doing. Number two, I stand in awe, having tried to run much smaller meetings with various degrees of unproductivity, and the fact that you can get people together in the room in your artful way and get something done is inspiring. The third thing is I was prompted an old memory. I may have shared this comment at an earlier presentation over the years, but when I was on my postdoc at the Menninger Clinic, they were doing a bunch of research around the idea of the difficult to treat patient. Everybody used the term difficult to treat patient, but they really were struggling with the idea that people had same language of the King's English, but very different concepts. So, the idea of a difficult to treat patient for the psychiatrist was very different than the nursing staff who often focused on, the sort of bad behavioral challenges. The social workers, their perspective on a difficult to treat patient had to do with dysfunctional families. And again, I think that this fundamental problem of Tower of Babel has been around a long time. And again, to have these tools that you've produced, again, I think such a great contribution. Thank you, CJ.
Well, I appreciate that, Ralph. Thank you very much. I'll just say one thing about, the difficult to treat patients. There was an earlier project on patient complexity that I did with my other department head friend, Mac Baird, where we took all those things about patient complexity of difficult to treat, the difficult patients, all that stuff, multi-comorbid, all this stuff, and tried to organize that. We did a series of paper and presentations, and we even did a thing twice at the Mayo Clinic in order to help them have a consistent language. Where we came down to, is patient complexity a property of the patient or really a property of the provider's reaction? And a whole lot of stuff like that. And we said, look, complex patient is one who the usual care guidelines and how you think about it don't apply because of patient-specific factors. And then we had a list of them and a scale, an assessment form for all the things that can make your usual care and decision-making stuff not apply to this person. And that stuff kind of grounded it. So yeah, that's a good one too. So just a long history of that. Yeah, thanks again.
You're welcome.
Charlie Cantor.
Thanks, CJ. It was a wonderful talk, and just as always, incredible complexity and clarity at the same time. You may notice that what I've been doing for the last several years is talk about communities that tend to fall apart, have huge amounts of conflicts, and go the other way. And you're going the opposite way and working on pulling people together and sharing worlds. I wondered, though, as you were doing this, what sort of major roadblocks did you run into, pitfalls, resistance? Are there some stories about that and how you had to handle that?
Well, I think actually, surprisingly enough, there weren't too many pitfalls. But I think the challenge was to, at the very beginning, the right kind of time at the front of a project saves time and grief over the life of the project. So a lot of it was in the original, like on that diversity equity project, was to sit down assemble a design team to say, here's what's the purpose of the meeting? How are we going to do it? What is the intellectual framework? And go back and forth and polish it up until you got that group of 7 or 8 saying, yeah, this really helped, this sings, and we agree. And I'll get up and talk about it too, not just me. So I didn't get up and do all this. I mean, we had the design team say, this meeting was brought to you by these people who are your peers. And so there was a sense of ownership, but there was a lot of slogging around at the beginning to arrive at the frameworks. And so that, if you do that early, instead of like jumping right in and saying, well, here's a good idea, let's try it and see what happens, let's see what sticks to the wall, that's a problem. So that was it. I think on the diversity thing, of course, that where the really the challenges are is in our carrying it off over the last 18 months. That we're going to present that next week at the family medicine thing, and that's where all the difficulties were. And I didn't mention that because this is about the conceptual thing, but we have what we call a messy middle that we're spending most of our time on next week, which is all the ways that you can get discouraged with this work. And then putting it in, there's like four things, but again, we're putting words on it and making it a normal part of a developmental path. And here's what you can expect. And here's how you're going to feel. And if you're a leader, you're going to feel really bad this way, but this part of it, here's why, here's how it works, and here's what you do. So then that becomes a normalized path, right? Because there's this energetic, enthusiastic starts. I mean, every one of you has experienced energetic, big, enthusiastic starts, and then, oh my God, you're in the middle of it, and it's like, oh, and then half the time it fades away. But you can do it. So that's where I think the hard part is. Right. And I think in the other one, the population health one, the natural tension I'm encountering is a lexicon that is about the usual talk today with all its flaws, so people can navigate it if they meet up with each other, versus the people that want it different enough, like they want the future version of it. And so we might have to have two papers. We might have to say, here's what you're going to encounter if you go out today, and then here's what these authors want it to be in the future. But the other thing is just takes a lot of care when you have a lot of people involved to listen to everybody, do rounds of synthesis. And is this what you meant? And can we solve that problem this way? So that all these, and like this population health paper, there were 12 authors. They all have famous reputations of their own. And so, it's a lot of important people that get to agree on something. But they were all felt like it was more important than they got their own little thing in. So that's a challenge.
Great, thank you.
Okay, and thank you, and on to Win.
Oh, hey, CJ. First of all, I wanted to thank you for the talk. Also, I'm a little under the weather, so I'm gonna try to be clear. This is a warning for the next talk. In the last 3 years that I taught at William James College before I parted ways with them, I had a full year seminar on consultation and supervision. I left in part because I wanted to reduce these courses to a lecture course with 90 people in one semester. But what made the last 3 years really interesting was that the second semester, they read your work. And they read your work in particular about how the issues of the lexicon problem. And they had an assignment for the semester, which was as part of the consultation group, and this was a group of about 8 to 9 students in each of the seminars. They were to go back to their work settings, and they're working as clinicians, and they were to using their own experience and then talking to the people around them, whoever they actually had daily interactions with, collect the terms that they thought were most often used, that were most often ambiguous or key. Then they brought them all back to the class. And we spent time, putting them on maps and then figuring out what their importance was, the different ways we thought they meant, seeing what kind of consensus we could get about the meanings. And then they created a list of those shared meanings. They then brought it back to most of the stakeholders for editing. And then we brought it back to the classroom. I gave them all an A, and it was a really enjoyable experience. And they were astonished at just the value of the dilemma of establishing a common lexicon. We tried something similar in a course on that dealt with personality theory, just in terms of the various kinds of meanings that people would throw around. And there we had to build a lexicon, but the lexicon problem is so problematic in our subject matter. And but it's a really useful teaching tool to get students engaged with the problem. And it made those last years, at least that part of it, enjoyable.
Yeah, that's just great when you could just do that as part of a teaching thing, not only to sensitize people to lexicon issues, but to actually help solve some of that for themselves. That's wonderful. It's, you could all do that. We are all facing that stuff. I think it's possible just to take it on. And, you know, I also, this reminded me what you said about the list, about the different terms that you came up with, how you synthesize it. It reminds me of something I meant to say. You know, when I showed you those lexicon diagrams for the population health, you notice that they weren't a glossary, like alphabetical, like a list, here's a term, here's the definition, that they were shown on a picture in a relational context. With top, goal talk at the top, implementing talk, stuff on the same level of the ladder along horizontally, and then concepts that were like part of something were tucked, the bubble was tucked in under one or overlapping, so that you were illustrating graphically the relations between these terms and not just definitions and silos. And I think that's one of the really important things is the family of terms are all at the same type of level and you can start recognizing them. Anyway, so no, great. I'll love to hear that story, Win.
Great, thank you for that. I'm not seeing any other cues in the chat right now, so I'll take an opportunity to ask a question. So you, CJ, you tackled a couple big ones. What's your next one?
You know, I'm not sure. I don't have one concrete one in mind. I'm still packing up, picking up the pieces after these two,
Right,
and disseminating them and presenting them and going out and evolving them. But I think the complex patient thing needs another loop. But so far, I haven't thought about that.
oh, that's fair enough. Yeah, as you say, still lots to do. Other questions for CJ?
So CJ, in I think a lot of this would be, I mean, all of it is totally relevant to people in other organizations, other areas as well. And do you have any thoughts about how to go about coming up with areas to look at in other organizations, how to think about that? Do you brainstorm key concepts that come up over and over again in each organization, or any thoughts about that?
Well, I always think of this as a very practical problem, not an academic problem to get the right meanings. So what I'll do is ask people to look for, where does differences of understanding become a practical problem for you, where you can't move, or you're in a meeting and you get stuck, and what does he mean by that? How is that? Everybody, when people experience a practical problem, so that's it. So then people will say, oh yeah, well, it's this and that and this and that, and then I'll ask them to say more, and then I'll take notes and try to get a better idea for it. But this thing is, it's a practical issue. You don't need lexicons when there's no practical problem. That'd just be an academic exercise to try to get the one true meaning for everything. It's when you have groups of people that can't work together very well, waste time. So that's a good place to start. And when you notice that, and ask people, are we here again? Has this been familiar? And then, like I say, I listen, and I can type as fast as people can talk. And I just listen and listen and listen, and then say, is this like, start that way.
Okay, well, we've had a pretty healthy round of Q&A. Grateful to CJ for allowing enough, a good amount of time for that. Any other questions or comments before I stop the recording?
And I work a good bit with physicians, and I'm an observer of these scenes. Some with I'm a patient in the UC health system. You run into the physician who gets a thing on stress management for the physician. That they're going to have a meeting on, they're going to have somebody teach stress management. And then there will be a rabble rouser in the group who says, how about, dealing with our hours reasonably? How about dealing with the health system? You can pose a question to your doctor at any time about anything, it seems, which is a tremendous demand on them. So you have this kind of administrative system issue. You have the doctors working within it, and then they put out a stress management thing. So I take it that do you have a history of dealing with that kind of problem?
Oh yeah.
I would think so. And I'm wondering where you could point me to just kind of know more about what's been done about that.
Well, the first thing is a major classification you pointed at, which is when people say stress management, a lot of doctors say, oh, they're just trying to show us how to continue to be beat up without complaining.
Right.
Okay, so when you say it that way, they all laugh. Then you have friends right away. You say, okay, there's two domains. One is all the things about practice that strain you. So that's the EHR. It's the this, it's the that. It's the fact that you have to log in twice, right? Yeah, every time you go off the EHR, you have to log in again. You can't have a constant. I mean, it's a lot of little stuff. So yeah. That's why I'm burned out. And then there's the domain of resilience, which is how you can swim higher in the water, so that the way you operate in your space, so that your nose isn't at the level that you're actually like up here, that your head is fully out more. Okay, that's something you can do regardless of how big the waves are. So there's the part about reducing the wave heights and the part about floating higher in the water. Those are the two domains, and we can work on both of them. See what I mean? Again, that framework sets a peaceful stage.
Okay.
I have a comment or a question.
One,
I'm always amazed at how you do these projects and present these products that are just incredible, CJ, and you've done this for years, and shown us how you go about it. But I know there are still these unwritten choice principles that you use as you approach each of these projects. And I wonder if there are some things you can describe about how you go about approaching how to deal with each of these. I know you've mapped it out for us in general, but anything you might add on that?
Well, I think in terms of engaging the people and around you to get going, a lot of that is stuff I learned from Tony. Because he supervised me on projects at my own place, and how to run great big meetings and how to engage people. So simple things like, what's the shared database of dissatisfaction with the status quo? Is there one? What is it? Can you put words on it to where people say, yeah, that's the problem? And then do they have is there a vision for like how it could be better? And then are there some first steps, and you're listening to people and feeding back. Is this what you're saying? Is this what you're saying? And then one of the choice principles when I take notes for groups is to say, I want to preserve as much of the original language. I want people to read these notes and they're going to say this. They're going to say, that's exactly what we said, but I had no idea we said it that well. See, those are little things. There's a lot of those, but that's stuff I learned from Tony for the most part, and have incorporated into it. That's why I pictured him on there, because the process facilitation, the process leadership that he had was really a key to making things work with people on the ground.
so thank you for that, CJ. We are at time. What a wonderful presentation and a great Q&A. I'm going to stop the recording now.